Right. So we're good to go. Right. So good evening, everybody, and welcome to BusinessLine Knowledge Series, a platform that discusses various segments of economy and the issues that confront the economy. Today, we are looking at healthcare, a segment that's pretty much all pervading, and even more so now with COVID. So, which is why I hope wherever all of you are tuning in from, you are safe and you're well. Even as we speak, the numbers of the pandemic graph are on the rise, whether it's in India or whether it's overseas. So we have on our panel today three very knowledgeable people who can help us get a grasp of where we are today and possibly try to navigate a little bit about unlock and where we can start preparing to looking at a post-COVID world. So without much ado, let me get down to introducing our guests. And I start with the lady, Dr. Swati Piramal, chairperson of Piramal Enterprises, and a very familiar face, so many people know her. She's, been very passionate on innovation and intellectual property in the past, and has also worked involved with various public health services. Welcome, Dr. Piramal, and thank you for being here. Then we have Dr. Srinath Reddy, President, Public Health Foundation of India, a very seasoned voice with public health. And in his earlier avatar, he's been the head of the cardiology department of the All India Institute of Medical Sciences. And a little bit of trivia here, Dr. Reddy's also been physician to two prime ministers in the past. So, and thank you, Dr. Reddy, for being here. We have our third panelist, Mr. Gautam Khanna, Chief Executive Officer of the PD Hinduja Hospital in Mumbai. Dr. Khanna also wears multiple hats. So he is also the co-chairman of FICCI Health Services Committee and the Vice President Association of Hospitals in Mumbai. Now, why is that important? Because he has an inside track on hospitals and how they managed to face the challenges when they first encountered the virus. So thank you, Mr. Khanna, for being with us today. Yeah. So I will, thank you. So I will get this discussion on the road with a question to Dr. Piramal. So ma'am, it's been 8 months we've been into the pandemic. And you have seen the way India is meant to have had the most stringent lockdown in that sense. So how have we fared? Where we are now, we are sort of unlocking, and how do we kind of prepare for a world post-COVID when we get there? So where we are now and looking ahead when we get there.
So this has been an unprecedented global crisis with, of course, health crisis and economic crisis, leadership crisis, and also a moral crisis and inequity in access. So what do we do in this crisis? And what I think that the answer would be in technology and innovation. So we have heard of vaccines. How will they come and how quickly and how will they be distributed to the front line, to people in the armed forces? So we have to think about the next steps very quickly on that front. I think that drugs will come faster than vaccines, and repurposing drugs will be very, very strategic, pivotal. Every country has to play its strengths, and India's strengths are two. One is its pharmaceutical industry and its large private healthcare system. So if we play to that strength, I think that we'll be able to navigate the crisis. And finally, I think the key, as Paul Romer, who's a Nobel Prize winner, and Michael Mina, my colleague at Harvard, just wrote an article saying that you have to test every day, not twice a week, not 4 times a week, not 14 days. Every day will come with the new tests that are paper tests. You can just put it as saliva in your mouth or near the nose, and within 20 minutes, you would get the answer. So, or really instantly. So I think that is going to be the game changer. If you can test every day, you can work safely, you can go back to school, you can go back to office, you can treat the front line. So I think the game changer will be the testing and the availability of drugs.
Right, right. And those are both areas that India has a strength in, especially with the availability of drugs.
That's right. Yeah.
Right. Right.
Because vaccine is complex. Who will you give it first to? That's mind-boggling question.
Correct.
If you X amount of vaccine, kisko pehle denge? You first give your armed forces, first give the front line, first give, fire safety, grocery people. I mean, it boggles the mind how we'll do this. And the
Right.
price.
Correct. Correct. Dr. Reddy, just to continue with this discussion, so with this line of thought, so Dr. Tedros had the head of the World Health Organization had recently said, 8 months on, and people are tired, and they're also now, ready to move out. But moving out without a recipe is a disaster. So just understand from you, do we have a recipe in place as unlock is the fourth unlock is underway, or are we headed for a sense of herd immunity, which one keeps hearing about? So
Let me start with herd immunity and then get on to what we need to do.
right.
Firstly, herd immunity threshold for this virus has been estimated variably between 40% to 70%,
Right.
even assuming it is about 60%. Firstly, everybody in a particular place has to cross that herd immunity threshold. If we assume that there are other forms of immunity like T cell immunity, which may not necessarily be detected by antibodies, which may fade away soon, still we are seeing currently immunity levels being recorded in large cities in antibody surveys at about 20 to 29%. It is likely that even if T cells have been activated, about 35% is the maximum estimate. But we have to reckon with the fact that antibody tests can be false positive because of other coronaviruses. And these false positives can be magnified in a general population survey as opposed to a hospital testing. So let us say somewhere between 20 to 30% in large cities have been affected. Now, in other places, it is far less. It is about, let us say, about 10 to 15% maximum, and possibly even less than 10%, as we are seeing in other countries. Now, it takes a while for all of India to attain that threshold. The reason why I'm saying this is herd protection. This is not herd immunity in the sense that everybody in that herd is acquired immunity. If 60% are protected because they have been infected, have recovered, and are immune, the remaining 40% are now being protected from the virus by the cordon of immunity that others have, and the circulation of the virus in that group continues to be blocked by the immune people. But if you step out of that particular herd or that particular community and go to some other place where the exposure has only been 10 to 15%, you're not safe. If you belong to the 40% who are not immune and you go to the other place, you're no longer safe. So if a person from Delhi, which assume, let us say, hypothetically crosses the 60% threshold, goes to Raipur or Ranchi, where the prevalence has been only 10%, that person is not safe. So for all of India to acquire that immunity, or all of the world to acquire that immunity in a place where trade and travel are so frequent, that is going to take a long time. So we need to take our precautions. And certainly, since vaccine is not going to be immediately forthcoming, nor is it going to be available to everybody, we have to live with care, caution, and confidence. Care in the sense, take personal protection in terms of ensuring that you are wearing a mask, practicing hand washing, and maintaining physical distancing. Caution in the sense, avoid crowded events, especially indoor events, and also proceed with confidence that you can, if you observe these cautions, can resume a fair amount of your routine work. But most important, avoid crowded events which are super spreaders, especially crowded indoor events, which can actually result in huge viral dissemination. So we need to retain our level of caution even as we start resuming our economic and social and scholastic activity.
So that really is what you're saying will be our recipe to sort of unlock and get back slowly into regular economic activity.
Yes, it has to be a graduated resumption of normalcy. It cannot be a sudden jump from lockdown to laxity.
Right. Absolutely. Very well said. So moving to hospitals, Mr. Khanna. So in the early days of the pandemic, we did see, especially in Bombay, that three of the hospitals were faced with the COVID situation. They had to shut down, and so they did eventually sort of get to they did have to quarantine, but then they did come back and they became COVID hospitals. So just to understand from you, what did that mean? I mean, how was it for hospitals to face the problem of the virus?
So, Jyoti, thanks for asking that question. Because I think it is important for everyone to know that this crisis was not known to hospitals and medical community. So there were multiple challenges, but let me talk about challenges on four fronts and the learnings which we got, all the hospitals got from there. So the first challenge was the infrastructure, the physical infrastructure. The key difference which our viewers need to know is that the COVID hospitals are negative pressure hospitals and regular non-COVID hospitals are positive pressure from the air conditioning point of view. That means the infection should not go out from the COVID areas. It should not spread elsewhere. So now to change the air conditioning in buildings is a mammoth task. And you have to understand at that point in time, lockdown, the labor was not available, construction was not so easily possible, the equipment was not available, the PPE was in short supply, drugs wasn't. So there was lots of challenges in terms of making the infrastructure. So I think that is one which most hospitals manage to do successfully. The other challenge is that in a regular hospital, as you understand, when a patient visits a hospital, they either go to a ward or go to ICU. Now, it is now suddenly into three. So when the patient comes, if they are positive, they go to positive COVID ward. If they are negative, they go to non-COVID. If you don't know, then you have to put a holding area. So suddenly from one ward, you have three types. From one ICU, you have three types of ICU. So suddenly the complexity in the infrastructure has changed. And then you need to have the safety measures for all the patients and the staff who are coming and working in the hospital. The second challenge is on the human resources front. Firstly, of course, the issue of availability of people. When there was lockdown, like in Mumbai, the trains were not there, the buses are not there. How do you get people to come and work for the hospital? So, of course, people like us, we arranged some 13 buses and got staff here. We also had to arrange for accommodation near our hospitals where the staff can stay. And then how do you make sure they continue to be motivated? Because we must understand that their families were worried, they were worried, and many of them were getting infected from the community. So how do you ensure that they are motivated? So that is a challenge which most hospitals have come up with and managed to bring back that program. And for example, for special programs for staff have been done to ensure mental health, some emotional health, psychological counseling, some spiritual help in terms of prayer. So lots of these things have been done. The other thing is the staff, when they got infected, where would this go? They would want to come to the hospital, but the government has issued guidelines that they cannot be admitted if they are asymptomatic or mildly symptomatic. But what is the effect of not admitting them to our hospital on the other staff? So, we arrange for isolation centers for our other staff. So you have to make all the arrangements. So that is the second challenge. Third challenge was from the clinical point of view. Clinical point of view, there was no knowledge about this. So people were learning all the time, the WHO, CDC guidelines coming, and then there was an experience from Italy and US and Wuhan. So our clinical teams were constantly in touch with Indian counterparts, international counterparts. And so one thing which we learned in this crisis is that if people say, I don't have any knowledge of it, I can't do it, I think it's wrong. I know we did not have knowledge, but we acquired it very, very quickly. So I think that was on the clinical protocols and making protocols. And the fourth challenge, which I think Dr. Piramal referred to in the beginning, is that, of course, it is a medical crisis. and we closed the electives, surgeries, and OPDs. So that resulted in a financial crisis. So suddenly, hospitals are not making money. So there was a study by Fickey and Ernst & Young, which said that estimated that in April month, that per month loss itself would be 7,300 crores for 75 hospitals. Now that is much more. So on one hand, you don't have patients, you have to treat for COVID, you have to motivate your staff, you have to spend, and then you are making a loss. And then the other thing is about the government regulations were always coming. So you have to cope up with the government regulations. And of course, government decided to restrict the pricing on COVID and non-COVID caps. So that also had an effect on many hospitals where some of them who were not able to, they didn't have enough reserves, they had to borrow money and all. So that is a little hardship. But the learnings we got from here is, I think what we learned is that in this pandemic, the ecosystem came together very well. The government, the private, the NGOs, everybody, they came together very well. And I think that is something to be said about the future of healthcare in India, that we need to work together. The other thing which came was the importance of preventive health. People suddenly understood why health is important. So all this time, all of us were talking about investment in stocks and land and property. Now we are talking about investment in health. So I think that is a positive learning from this pandemic. And the other thing is, many of us, we re-examined our priorities, that in this crisis, how do you do? For example, we said, whatever happens, we have to deliver quality healthcare for all as per our founder. So everybody went back to the roots, re-examined, and did this. So hospitals have learned a lot. We moved to digital era. We did video consults. I mean, things which we've been wanting to do for 6 years, we did in 6 weeks. I mean, patients, like, for example, we've done more than 12, 13,000 video consults, which is a huge benefit to the patients. So that, plus, you do teletriage and lots of things are digital. So I'm just going to say that lots of challenges, but I'm happy that all the hospitals in the country came through it, although with difficulty, and now we are ready to handle the COVID patients. Thank you, Jyoti.
Right. Right, that's very extensively explained. So, learning pretty much on our feet was something that seems to come through. Dr. Piramal, you sort of alluded to this in terms of repurposing drugs and fast track vaccines. Is this going to change the way science is going to be looked at in the future? Because earlier we have, it takes many years to get a candidate, to develop it, and all of that. And suddenly we see in 1.5 years, or even just matter of months, we are actually talking about having a vaccine. Of course, there are questions of safety, but will the basic model of developing vaccines and repurposing drugs, and will the science sort of also change now, given this experience? Yeah.
The things, as Mr. Khanna noted, that in hospitals, doctors were talking to each other. But scientists was really collaborating with the speed of sound. When in the beginning we were making mistakes on antibody tests and saying that they were wrong, actually it was too early. We actually talked to people in Stanford and Milan and figured that antibody tests actually are for later and not early. So that way scientists are collaborating with the speed of sound. So repurposing drugs, I think, is a very good strategy for India. Unfortunately, I don't think it's as fast as I would have liked it to be. For example, what the British government did, they went back to the animal trials of all the known drugs, and they looked at the safety records, and they looked at how effective they were in cytokines, because that was a big problem, and that's how people got into the ICU. And then they did a trial of 5,000 people inside 1 month for dexamethasone. And today, 3 trials have proved that that really works. And steroids is now going to be a cornerstone of the standard of care. So this is the way of strategic thinking a government should do. They should look at all known drugs. They should look at what's available, go back into animal trials, maybe 30, 40 years to see how safe they were in cytokines. And we are trying to do, our company is trying to do some sort of strategy like that. But it needs to be a national strategy. It needs to be people thinking, what can I do to get vaccines faster, what will be the distribution strategy, how to get drugs very quickly, how to make them affordable, to go back in time, and to reduce the biggest problem that we have is a very old regulatory system. It was written during the time of independence. It hasn't really been refreshed. The people who are expert committees usually are part-time. They are, retired, either doctors or scientists. And it should be like the US FDA or the UK FDA, where they're full-time, very well paid, and very specialized in their field. I was talking to the UK vaccine, Oxford vaccine, was hearing how efficiently they are thinking about doing it. And India has to really revamp its regulatory system so that we can meet the strategic goals of treatment very quickly, using our pharma industry strengths, using repurposing drugs, thinking about how vaccines will be distributed, and revamping an old and creaking regulatory system which was written at the time of independence, and really rethinking the future. How fast can we go? How quickly? How safely? How can we distribute? How can we manufacture using India's strengths?
Right, absolutely. Dr. Reddy, how would you as a public health person see this whole fast tracking of vaccines? What are the pitfalls one needs to watch out for when we are talking vaccines especially?
Well, there are several ways in which we can speed up the vaccine process, but there are also certain stop signs that we must observe in terms of slowing down where necessary. We cannot stampede science just because we perceive a public health emergency. In terms of phase 1 and 2 trials, if we can quickly complete them and even simultaneously start recruiting to phase 3 trials, we have everything ready to go. Then we can actually have assembled large enough numbers to have a sizable phase 3 trial going as soon as possible once the results from phase 1 and phase 2 are evaluated quickly. And then that will cut short the time of phase 3, and which in India with large numbers we can actually do. But the time taken for actual development of immunity, assessment of the immune parameters, as well as the safety measures, there are three things that you need to do when you're evaluating a vaccine. First is efficacy, second is safety, and third is the duration of protection. You may not be able to get much idea of the duration of protection from a phase 3 trial, but nevertheless, you can hazard a guess based not only on antibodies, but also on T-cell activation. But safety and efficacy are absolutely non-negotiable entities. In terms of safety, it's very important because there is something called antibody-dependent enhancement, where we have seen in some of the past vaccines, there have been serious adverse effects, and those vaccines have been discontinued immediately during the trial process. Similarly, there could be other effects like immune complexes circulating and causing problems. So we need to assess the safety very clearly, because you're giving to healthy people, you're not giving it to patients. So there is a great ethical responsibility there. Secondly, in terms of efficacy, yes, we need to ensure that there is a sizable immune response and there are neutralizing antibodies as well as a good T-cell immune response. And we have also seen in other vaccines that there is what's called the original antigenic sin, where because the vaccine is actually produced using a fragment of the virus or an inactivated virus, the immune response is active against that fragment, but not against the real virus itself. And that has been seen also in some of the other vaccines during the trials. So we have to be very sure that we are getting the right kind of vaccine. But speeding up the process in terms of recruitment of people for trials, that is certainly possible. As I said, you are actually using sound science for research, but you're investing in hope. You have to wait and see whether that hope pays off or not. So we have to really see whether we'll get the vaccine that we are dreaming about.
Right, absolutely. Lots of hope pinned on that. That is true.
Yeah, in addition to time of immunity, Jyoti, if I may say,
yes, please.
in the of the disease is the immunity goes away in 2 or 3 months.
Correct.
And if we give a vaccine and the immunity lasts only a few months, then we have to give a booster dose. And those things are worrying because you may think that you are vaccinated, but then you go out into the world and you're not actually safe. So there is a lot of work to do to help to get the vaccines across to every patient or every
Absolutely.
volunteer rather, or healthy person.
Absolutely. And in a country like India, the whole logistic issue of rolling it out to, to the across the whole country.
Especially
Yeah.
if you have to give 2 doses.
Yeah.
Absolutely. Absolutely.
Polio, we have just about managed after so many years. So
Right.
distribution, the logistic nightmare.
Right, absolutely. Yeah. Mr. Khanna, with hospitals, you've just said that, you're beginning to get back to, OPDs and electives, surgeries and all of that. It's one thing to deal with, your own staff and, their fears of, the whole COVID pandemic. Are you managing to get people and patients coming back to hospitals, because people are still scared to go and meet their doctor? So um, how is that really working in the opening up?
what what is happening is that this issue is real, what you talked about, that the patients are really worried that if they visit the hospital, what's going to happen. So I have a couple of comments on that. One, of course, the hospitals are taking a lot of care and adequate precautions. I mean, for example, if you come to our hospital, there'll be a separate triage area. There'll be, before anybody enters the building, there'll be screening, there'll be hand sanitization, thermal screening, all those kinds of things, and everybody will be masked, and we have designated areas as per the risk qualification. So somebody will be in full PPE, somebody in full mask, only mask. So there is a gradation as per the science behind it. So patients need to know that it is safe to visit the hospital. However, having said that, we also know that now digital is taking a lot of part of our lives. So what is now happening is that more people are preferring to do things at home. So one of the models which is going to emerge uh, more in future, and we have been doing that before at home care services for us, but now it's going to work that can we do more and more services at home. So reduce the hospital stay, get home. And for example, in this COVID, one of the things, I'll give you an example. So people who are asymptomatic and they have to be at home, so they can't visit a hospital, but they are really scared. What do you do? So we've launched some COVID home care packages where our doctors will monitor for 14 days and nurses will monitor every 8 hours vitals. So those kind of things, that is a different model. And now after COVID goes away, this kind of model will exist. And I already talked about the video consult. So that is there. The other thing is about, for example, surgery. Now, for surgeries, our surgeons have developed protocols based on international guidelines and Indian guidelines. And now they know that what kind of surgeries are risky, at what level, how many times do you test. So those kind of things are taken care of. And I think one thing which has emerged very strongly in this pandemic is the patient's need for information and education. So the more and more we are able to educate, for example, we've been trying to do that with videos and social media. More and more we educate, the patients are actually looking for that information. So they read about it, they understand, and if they have a question, they do. So I am seeing the confidence coming back to people, because I think, like Dr. Srinath Reddy said and Dr. Piramal said, that the vaccine is not going to be the answer to everything. The lockdown has gone away, virus has not gone away. The other diseases have not gone away. So you need to get treated, and you cannot just postpone your treatment because of COVID. So you have to take care. And as long as you do, like you mentioned, physical distancing, hand sanitization, and masking, these are the three things which will save everybody. And if I practice it, I save somebody else. And if that person practices it, they save the other person. So we all have to do it together as a community. So I think that if we all understand, and one of the good things about this COVID, again, I'm saying, it has brought the importance of hygiene into our lives. So the fact of the matter is, that many of us have learned to wash our hands, which our doctors and clinicians have been saying for ages, that you need to wash your hands, and how you sneeze and how you cough. I think that is come back into the psyche. So I think we are going to see a uptick, and many hospitals have started seeing the non-COVID patients coming back. The only challenge there is that since our staff is deployed for COVID, now you don't have enough staff for non-COVID. So that once that is the only reason why some hospitals are taking it slow. But once that staff shortage is taken care of, they will be back to normal.
Right. Even with your staff, you've had to do a lot of, did you have to do a lot of counseling and speaking to nurses and ward boys?
Oh yeah. So I think one of the things which we learned, and I personally learned this in this crisis, is that there is nothing which is less communication or more communication. I think everything needs to be more. So personally, I've done communication at all levels: personal meetings, emails, conference halls, town halls, Zoom meetings with all categories of people, and just to talk about and reiterate the basics of what we need to do and why we need to do. And if people are scared, and I'm going to take this example to talk about. For example, we launched a program called Sampark. Sampark in Hindi and Marathi means contact. So that is a combination where we have inbuilt a program for physical health of people, mental health of people, where you have some, counseling and psychiatrists, and then you have emotional health, you have quizzes and music contests and so on and on. And then you have some spiritual part where you have meditations, prayers, and then you have communication sessions, town halls, suggestion boxes. So, you have to do it with all people. And sometimes, and this is my learning, I thought the people who are seniors don't need it, or people who are very educated don't need it. I was surprised. So it's not that only the worker needs it, everybody needs it. So that anxiety level is high. And one thing we have understood is our vendors and suppliers, they are also looking at reassurance from us. So I think one of the things is that we've had a chance to talk to them, to bring them into the partnership role here, saying that we are in this together. So we swim or sink together. So I think that all is a very, very important part of how healthcare has been able to, I'm talking about private healthcare, has been able to deliver the care to the patients in the country.
Right. I'm going to stick with you, Mr. Khanna, because you are representing private healthcare here. So one question that often comes up is to do with pricing, and we've seen this with the pandemic. We've had price control. Several states, sort of brought in price control. Some of them took over hospitals. Some of them spoke about nationalization. Now, the one thing we know is this is not going to be the last pandemic. Unfortunately, we probably are going to see more of these things. So how do you in the industry, how do you all speak about this, where it's not like anybody wants to shut down hospitals, because at the end result patients will suffer, but at the same time things need to be affordable, from diagnostics to medicines to vaccines to ICUs, ventilators, the PPEs, the list is long. So what would you say there?
So Jyoti, okay, let me just uh, put it in a perspective for you. So one thing which this crisis has done is it's brought back the importance of healthcare for the economy. Earlier, healthcare was not considered significant for the economy. So now we know if healthcare is not there, economy is not there. So that I think is a good thing. The other thing which it has brought about is this question which you talked about, that people are thinking it's expensive and so on and on. Now, my question to people when they ask me this question is that the prices which were there pre-COVID, let's say December 2019, has anybody increased prices more than that? The answer is no. So all the prices across private healthcare and is different depending on the quality and the service levels you offer. Now, people might say that government is free. Government is not free at all. It is being paid by mine and your money, the taxpayers' money. So there is a cost of healthcare which everybody has to give. There, the government is paying. Here, the patient is paying. Now, if you think about it, that when we want quality healthcare, we want international quality. The equipment we buy is global in dollar prices. The doctors are being paid, the staff is being paid, the land is being paid for. I mean, city like Mumbai, the wages are very, very high. So the costs are high. And especially for people like us, like who are not-for-profit trust hospitals, obviously we take the money and put it back into the hospital. So nobody's making money. So the issue is the costs are high. Now, the easiest way to do anything is to say, reduce the price. You're not reducing the cost, reduce the price. When you reduce the price, so ultimately cost will go down. At some point in time, you will start compromising on quality. So what's the answer to that? The answer is that you don't go into downward spiral of pricing. The answer is, when I go to buy something, I'm buying a service. I need to have enough money to afford that service. So look at the insurance in the country. I'm going to say this pandemic has exposed totally that people in the country either are underinsured or not insured. So if I have an insurance of 2 lakhs and my bill is 3 lakhs, I think it's too expensive. But if it's the other way around, I think it's fine. Or if I don't have any insurance, then even 50,000 is too much for me. That I think is a understanding which we need to have, that this COVID, the problem is earlier, people used to be in hospital for 3, 4, 5 days. Now suddenly it is 15 days. So 15 days of ICU versus 5 days of ICU has hit them that the cost is too much. It is a lot. But I think the answer is insurance. And and the ability to pay. And my request has been to the companies and my friends and all the people who are here is that think about it as when we go and buy a motor car or a motorcycle or a truck or whatever, insurance is mandatory. The most precious asset or vehicle in this world is the human body, and insurance is not compulsory. So I think there is a disparity. So we need to ensure that everybody is insured, and then companies need to make insurance mandatory. Take it part of their salary. Just take it and make it mandatory. Focus on preventive health. Focus on health checks. That I think is the answer. Now, whether the pricing will go down, the thing is, India is not a homogeneous state. We are not all poor. We are not all rich. There are different types of segments in the society. So somebody needs a Maruti car, somebody needs a motorcycle, somebody has a bullock cart, somebody needs a Mercedes. So if you want a, in a hospital of international level, which you don't want to go abroad, but you don't want to pay, and you want to pay the price of a very low quality hospital, it's not going to work. So I think the important thing which all of us have to understand is that we need to have our model, that how can we give offerings for different segments of the population. So if one segment needs one quality and service of care, you do that. Second, of course, clinical quality you never compromise. You give same clinical quality to everybody, but maybe the air conditioning is different, maybe the facade is different, and so on. So you differentiate that, and maybe you need to have models for smaller single specialty hospitals and things like that. And I think the other important thing is what this pricing does. And I'm not talking about now. So now, of course, low pricing, some hospitals will close down, some will be bleeding for a while, and then they'll figure out what is to be done. Some will manage because of their reserves. But what it will do, it will send a signal to the industry that new investment in healthcare should be done very, very carefully. Because if you know that if I invest and I'm not going to get a return, who's going to invest? So the only person who has to invest is the government. And I'm very happy if the government invests. Right now, and Dr. Reddy's team had done a study on that 1.7% of the GDP was being spent on healthcare. They had said that it should be 2.5%. I'm saying you combined of private and public is around 5 and 6%. Government can do that. If government does that, we all will be very happy. But reality is, we will still need private players. We will need not-for-profit hospitals. And so we need to make sure that there is an incentive for people to invest. Everything cannot be done out of goodness of heart. We will do charity and goodness out of heart for some time. But the scale which India needs, for that, you really need to get some special incentive for the healthcare sector, whether you want to give it to the not-for-profit hospitals or for profit, I don't care. Just ensure that there is some investment in healthcare. And the other thing, the last thing I'm going to say, is my request to the citizens of the country, and of course your fellow colleagues and press, is that, you know, there are 100 cases or 1,000 cases being treated in every hospital. One goes wrong. What makes the headline? That 1%. And what that does is that with so much negative press and negative feedback from the social media and so on, the healthcare workers, they get completely demotivated. The doctors, the nurses, the staff, the housekeeping guys, and the stores guys, they are saying, why am I doing this? I mean, here I am taking a risk, coming to the hospital, taking care of the community, and I'm not doing it for money. I'm doing it because I really want to do it. And I'm facing so much negative criticism. So I'm just requesting all of them to just pause for a second. When you get some negative news, before you pass a negative judgment, just pause, think about it, and just recognize the good effort which the hospitals are doing. So if everybody was bad, how would this population have survived and got treated for so long, millions and millions of people? So I think that's my only request to you, Jyoti, your fellow journalists in the other publications, and to the citizens at large. I'm going to stop at that. Thank you.
Well, that's food for thought, but little alarming to hear when you say hospitals might be facing a shutdown or some such thing. But Dr. Reddy, you've looked at universal health insurance quite closely. How would you suggest that we look at look at this in the long term in terms of health financing?
Well, we use the term universal health coverage, not universal health insurance.
Correct.
For the simple reason that even if you say that people who are employed can pay a certain part of their salary to insure themselves, we must recognize that 90% of India's workforce is in the informal sector. So payroll deductions are not really possible there. And we also recognize that there is still a large portion of our population living under the poverty line or just above the poverty line. And we know both from the 2004 and 2014 NSSO surveys that 7% of the population is threatened with poverty or actually may experience it because of unaffordable healthcare expenditure at any given time. So we do need an increased public financing. We cannot do without that. It has to be tax funded, supplemented by employer provided funding, insurance, and also private insurance when purchased, if people want to purchase it. But ultimately, we do need to pool all of that as far as possible into a single payer system, which offers a great advantage of a negotiating power to the purchaser so that you can have price and quality control. It expands the risk pool and can provide you a more extensive service package. So we do need to do that over a period of time. And certainly we have to have that level of public financing in order to make this happen. And that is what was committed even in our National Health Policy of 2025. And unless we recognize that investing in health of the population, as has rightly been pointed out, is not only a necessary service, but also an important lever for economic development of a secure social system, because otherwise you're going to have a destabilization even if there are a large number of people falling ill. So you do have to invest in health for a variety of reasons. And that requires a very strong universal health coverage scheme, where you can actually combine multiple streams of contribution, some of which can be insurance, employer provided or private, but unless from the tax revenues we spend a fair amount of money, much more than the current expenditure that is available at this point in time, which has been ranging from 1 to 1.2%, will not be able to really establish that kind of a coverage for people.
Absolutely, yeah. Do you think now, given the pandemic, response and the experience, health will finally get some sort of attention from the authorities?
Well, usually whenever there is an outbreak or there is there are children dying in Gorakhpur hospital and the newspapers play it up, obviously with great alarm, then there is immediately a question is why is our health system so poor? Why is it so poorly financed, poorly equipped, poorly staffed? We must do something about it. And in 15 days, everybody forgets about it, including the media. But this time we are seeing a protracted epidemic, a pandemic actually, and we are seeing a continuous suffering of people, both on health grounds and on economic grounds, lost wages, lost education, and so on. And I think there is a much greater attention to the fact that we do need to invest in a stronger public health system and a healthcare system, both to prevent epidemics as well as to anticipate their occurrence early and try and stall them as much as possible, but at the same time to provide robust health services with equity and efficiency to everybody. So there we do need, I think, a little more political commitment to be consolidated, and that's where all sections of society can articulate that demand continuously, that we can no longer cope with a weak and inefficient healthcare system. And we do need that system of very consolidated healthcare system, which brings in the public sector, the private sector, and the voluntary sector together in a well-organized fashion, even in the steady state. You cannot suddenly ramp up your services or scamper around for ad hoc partnerships when a crisis is at hand. You have to do it in the steady state. And that is where you have to predefine how you're going to have a strong public system and also have the private and the voluntary sectors brought in as partners, but on well-recognized templates of partnership, which provide for very clearly defined deliverables on the part of everybody, as well as very clearly defined accountability mechanisms. So we do need to redefine the architecture of our entire healthcare system. And then we do need to invest in money, but also get greater efficiencies for the money that we are spending. More money for health, but also more health for the money. So we also need more allocative and utilization efficiencies. Unless we plan to do this in a systematic manner, every time there is a crisis, we'll cry that our health system is inefficient, we must do something about it, and a month later pass on to some other crisis. So this time around, we cannot let this opportunity pass. Fortunately, the 15th Finance Commission has recognized the need for a strong health system. Even before COVID-19 pandemic came in, they constituted a high-level group, and they are making recommendations for greater allocation to health system, particularly strengthening of primary healthcare and district hospitals, and also a greater investment in health workforce. And post-COVID, they're revising their recommendations, asking for greater allocation to health, both at central and state levels. We are waiting for that report. And if that report actually delivers what it promises, I think finally we'll see a shift in the direction of healthcare financing towards universal health coverage.
Absolutely, fingers crossed on that one. But would you be suggesting, a larger percentage of allocation, more than 2.5%, that has been committed for a long time now?
Well, 2.5% was what we had recommended in 2011 to the Planning Commission to be achieved in the 12th five-year plan. Mm-hmm. And we said minimum of 2.5%. And we said subsequently it should start increasing incrementally in every plan period. So the National Health Policy of 2017 says that we'll have 2.5% by 2025. But we are not seeing that happening now, and certainly not even happening at the state levels, because it's not just central allocation. State spending is also important. So we need to ensure that now we actually do a front-end spending of a larger amount right now, and increase it from 1.2% to maybe 1.8% straight away, so that we can invest in infrastructure, health workforce, drugs and supplies, and give that push to the health system that it desperately needs to get going. And then we can start incrementally every year increasing the allocation by 20% or 25%. till we actually reach the optimal level. So unless that is going to happen, and we have to find the funds for that, we will actually be dealing with a very weak and inefficient healthcare system, which is continually going to pose a challenge to our economic stability as well.
Absolutely, absolutely. Dr. Piramal, I'm going to ask you the same question on health. Do you think health will get greater attention now, given what our experience has been over the last 8 months with life and livelihood taking a real beating?
Yeah, so I think here, Jyoti, I'd like to touch on the role of innovation. Because if you look at the cost of what we have talked about today, the cost of hospitals, the cost of universal healthcare coverage, the real cost, which can be the lowest of all, is drugs and pharmaceuticals and vaccines, as compared to the cost of hospitalization. So it's better that you prevent, it's better that you treat early with drugs and pharmaceuticals, which cost anywhere between 10 rupees to 1,000 for a vaccine maybe. And so we must bet on the biggest bang for the buck. And that is actually India's strength of pharmaceuticals and R&D. And using things like supercomputers, looking backwards at which drug can work in this disease, looking very quickly at repurposing new drugs, shortening the clinical trials, increasing the number. There are 1,800 clinical trials globally, but a very small percentage in India. How can we increase that? The role of the regulator, decreasing all the bureaucracy and the red tape, increasing the approval time very quickly. So those are things that we can do very fast and without great spending and just being more efficient. That's one. And the second thing I think is that while we have talked today about cities, hospitals, and we've talked about universal healthcare coverage, but what about the rural areas? And that is where the large masses of our population are, and yet the resources are so poor. And what should we do about that? And here are experiments that foundations do. Piramal Foundation, for instance, is working in the 100 aspirational area districts, the poorest, with the weakest indicators, health indicators, and trying to do work in those areas to improve healthcare delivery, healthcare efficiency by mobile healthcare services. We have something called the Dada Dadi Abhiyan, which has worked so well for the elderly, protecting the elderly in the poorest areas through voluntary effort. Volunteers calling and picking up the phone and saying, here are the nearest healthcare facilities. Here is how you must protect yourself. This is what you must do, because they are the most targeted for the virus. And so I think the role of innovation, the role of using supercomputers, the role of, is going to benefit. And when we use what Dr. Reddy mentioned, the 5 public health pillars, the mask, the hand washing, it has succeeded. Today morning, I read the American Airline Association. They haven't had transmission across all their million flights that they're doing because they're following the distancing rule. They're following, all the hand washing, hand sanitization, and all those efforts. Transmission has been low in the pharmaceutical industry, which has been running during COVID as an essential service, because every worker washes his hands, uses masks, his hand sanitizes, temperature control, the 5 big pillars, and the culture of the organization is so that efficiency is recognized in treatment of COVID, prevention rather. And so I think the pharma industry has been the lodestar. It has already worked. It has showed that transmission is low. It has worked during COVID times. And what it does is the lowest cost, the biggest bang for the buck. So if I had 100 rupees, I would bet on drugs, pharma, and vaccines.
Right, absolutely. You did mention innovation, so I'm going to take some questions from the audience here. There is a question from Manaswi Mathur, and she's asked, would the launch of the National Digital Health Mission during the COVID era be useful for COVID healthcare systems? Dr. Piramal?
Yeah, actually, if you think about it, because I run the pharmaceutical industry, we were not allowed to do telemedicine. We could not prescribe medicines through the phone. It was actually banned. Now, COVID has changed all that. And, virtual healthcare, virtual signatures are very much on the cards. So what a change. We were banned from using telecom. We were banned from using digital. We were banned from selling medicines on the internet. And now suddenly all that has changed, where the medicines should be delivered to the patient on the doorstep rather than him going out and buying things and going to the hospital. So it has been a sea change in healthcare, and I'm happy about it because I think it can lead to a much lower cost. It can lead to more transmission of knowledge across the system globally. You can talk to a doctor anywhere in the world at a fraction of the price. And so I think those efforts will be really helpful, and the digital healthcare mission will certainly make a big dent in helping combat this virus.
Right, certainly.
More than that, I think it's a supercomputers, the more using, digital, using computers, which we did not in the past. We were always, just one pharma company at a time, not sharing information. Today, it's so quick. You have to register your trial. You have to give the data. The data is scrutinized by everybody in the world. It's an amazing, amazing time for knowledge sharing and knowledge distribution and knowledge transmission.
True. It's been quite outstanding how scientists are working with each other. Dr. Reddy, there's a very interesting question that's come up on the long-term implications of post-COVID care. We are hearing that even as people get back, they have symptoms for much longer. So, what would you say on that? And the other thing is on non-COVID related treatments getting a setback, whether it's TB and polio and all of the other immunization programs. Yes.
Well, as far as the long-term effects are concerned, we are seeing reports of people having severe fatigue as a residual symptom, or sometimes even more serious issues like lung fibrosis or even myocarditis with muscle injury to the heart, or other problems also coming up, including some neurological manifestations. But the actual fraction of these among all the people who are suffering COVID is not very high. Especially if you're young, then you're much more likely to recover without too many problems. Though myocardial injury by imaging has been found also in young people who have recovered and become asymptomatic. We still need to watch out for the long-term effects, but it appears to be a variable effect across age groups, and because also depends on the associated comorbidities. But this is not just a fever that comes in for a week and goes away as previously thought. It does seem to have some long-term effects in at least a fraction of the people, and we'll have to keep a watch on that, provide continuity of care, and also, if as necessary, ensure that their care is provided as a part of their health coverage package, however financed. So those are important elements that we must look into. The second question that you raised was on?
TB and other immunization
Yes.
programs getting hit.
It is true that the non-COVID conditions have certainly been affected. There's no doubt about it. And whether it is maternal health in terms of antenatal checkups or child immunization, or even in terms of infectious diseases like tuberculosis, all of these have been adversely affected, as we have seen. And this is again a reminder that you cannot function with a weak health system, because even for a public health emergency, a health system that has not been functioning efficiently in the steady state cannot suddenly create a surge response, leave aside, handle the competing demands of multiple conditions which are routine alongside the emergency itself. So if you have a health system that is already hopping on one leg, you can't expect it to race ahead either for the emergency or to deliver care for the other issues. So we do need to invest much more as quickly as possible. Having said that, our healthcare system now can actually start looking at our other problems, because we now recognize that much of COVID-19 cases can actually be handled in primary health care, home care. Many of them are relatively mild and can be handled there. And also that many of the people can be treated without ventilators. So even secondary healthcare centers can actually handle this. So we can actually manage some of the COVID cases with part of our health workforce, maybe if necessary with citizen volunteers helping in primary healthcare, so that all of our primary healthcare staff are not necessarily only assigned to COVID related functions. It is time now that we start redistributing the functions and then attend to other healthcare needs as well, because we'll be creating a secondary public health disaster if we actually focus only on the primary public health disaster.
Correct. Absolutely. So there's one question that's come up on trained personnel. So I'll take that to Mr. Khanna. The thing about having hospitals and infrastructure is one thing, but to have doctors, that is the other big challenge that needs to be addressed, isn't it?
So, Jyoti, one thing which this pandemic exposed in the country is that we've always been talking about shortage of doctors, shortage of nurses, shortage of paramedical staff, and the number of beds are not sufficient. In this pandemic, it has come out glaringly that there is a problem and this problem cannot be solved. So it is not something which will be solved in a short term. So of course, we need more specialists. I mean, we know that there is a shortage of ICU specialists. There is a shortage of nurses. So simple stuff that even you cannot provide basic care if you don't have doctors and nurses. So that has been there. And in one hospital I'm aware of, they have shortage of technicians. So there's nobody to operate the equipment. So the point is that this is something which we knew all this while. We knew there was a shortage, but I think now this has to be tackled at a war front. So there are two ways in my mind. One, of course, is the more and more digital we use, that we will, with digital technology, we can reach more people with less, more patients with less people. So that we can do, for example, digital home care or digital services. If I can do digital lab, digital diagnostics, so things like that. If I can do digital part of the healthcare delivery, that will take some stress away from the numbers. The other thing is we need to increase the number of DNB seats, the number of post MD seats if we want specialists. The number of nurses needs to increase drastically in the country. And the dichotomy here is we know that the number of nurses are less, but you also know that the College of Nursing, which are schools, the many seats are vacant. What this shows us is that many people are not interested in taking up nursing as a career. So if they are not interested in taking up nursing as a career, it's because either the conditions are so stressful, or the pay is not enough, or the future is not secure. So we need to tackle it at multiple levels to ensure that we start getting more and more students, and more students start graduating. Similarly for paramedical. So now we need, for example, we run an allied health sciences courses. We need to train more respiratory technicians, more ICU technicians, more emergency technicians. So we need, and everybody, I'm saying we means all hospitals, we should take some number every year to train as paramedical staff. So I think when we do it together, and like I said in the beginning, one of the good things about this COVID is that everybody worked together, the government, the private, everybody worked together. So I think going forward, government and private should come together and say, how can we help each other? We all know there is a shortage. Can we do something about it? So I think that has to be a dialogue and decided mutually, because it is for the benefit of the whole country. So I completely agree with that.
Right. A lot of questions also coming up on the regional disparity in the health care infrastructure. A lot of the hospitals being very city specific or city centric, and rural areas not getting attended to. So, I'll pass that question around, maybe starting with Mr. Khanna. Yeah.
Yeah, let me take a shot at it. So, I mean, I say that 70% of the India's healthcare infrastructure and healthcare is provided in 30% of the country in the towns for 30% of the population, which is urban. So there is a huge disparity. So I completely agree with you. Now, what we need to also understand is that the treatment, the continuum of treatment is primary health, secondary, tertiary, and then super specialty quaternary care, level care. What is happening is somewhere down the line, our primary care, primary health care has been not so much in focus. So what has happened is people have started crowding the tertiary hospitals. What we need to do is we need to strengthen our primary healthcare, the secondary healthcare, and those at the tier 2 towns or tier 3 towns. If we strengthen that, you will be able to alleviate a little bit of requirement for the healthcare infrastructure. Having said that, we also need hospitals in the tier 2, tier 3 cities, rural areas. We definitely need. But what we need to know is that thinking holistically, when somebody opens up a hospital in a small town, what will incentivize a doctor to go and settle down there, nurses to go there, the staff to go and work there? We need to think of it in a holistic manner. Just providing land and money for making a hospital is not going to make a hospital. Hospital is made of people. So I think that has to be thought through. So when I talk about the incentives and the some push from the government, I'm talking about these things. I mean, if there is not a if you put in a small town and there is no good school for children, there is no good residential places, the very difficult for city people to migrate to smaller places. So it is a much bigger problem. I'm not saying it can't be solved, but I'm saying these things have to be thought through before we embark on this journey.
Dr. Reddy, you would like to address that?
In terms of finding people to go to villages, yes, I believe it's very important, as has been said, that we create the facilities for people to go there and ensure that we also pay them well. Unless we do that, we are not going to attract people to go to the villages as in the manner required. We do need to produce more of healthcare providers in each category so that there are sufficient numbers to go there, but at the same time ensure that the service conditions are also improved. Just to mention the issue of nurses, because it was said that there are vacancies in the nursing colleges. Well, paradoxically, 2020 is the year of the nurse. It is the bicentenary year of Florence Nightingale. But why are our nurses reluctant now? It is because we have failed to improve the scale, the skills, the service conditions, the social status, and the salaries of nurses. We need to do that. We do need to create healthcare teams consisting of doctors, nurses, and allied healthcare professionals who can actually function at each level of care. And unless we do that in sufficient numbers, but at the same time incentivize them to do the work, we are not going to see our rural areas well attended. And other element I would like to mention is you do require a great deal of community engagement and accountability. It is because the decision makers and the health system managers are sitting in urban areas, they are not going to feel the pinch of a poor rural service. You hand over a good deal of the healthcare management of primary healthcare centers, or at least get their engagement in the decision making of primary healthcare centers to panchayats, for example, like in Kerala. Things will improve because the local politician then will feel the heat. Therefore, you have to make sure that there is a community engagement at the rural level to ensure that rural services are improved in an accountable manner to the local constituencies.
Right. There is one more question for you, Dr. Reddy. I'm just going to read this out. Higher positivity among healthcare professionals is being flagged as a concern. Many states have positivity rate in much higher proportion than the population. How do we deal with that?
Is it for me?
Yes, Dr. Reddy. the higher positivity among healthcare professionals.
That is very unfortunate. And we are also seeing that even young people who are otherwise supposed to be having higher levels of protection against COVID, because age is supposed to be protective in terms of younger people being less susceptible. But we are seeing young doctors and nurses are also being affected. That is because of several factors. One is repetitive exposure to high viral loads by being exposed to multiple patients. That is happening, and that despite all the PPEs, it is likely that there is going to be some problem, and we need to look at that. The second is the level of workload, high exhaustion levels as well, and that is also going to undermine their immunity. So we have to have a sufficiently strong health workforce with which is capable of rotational duties so that every healthcare worker is not overloaded during this period of emergency and becomes susceptible. So we do need to provide them the right kind of equipment and also the right kind of working conditions. Otherwise, we will see healthcare workers also being much more vulnerable.
Absolutely. In fact, there is one question for Mr. Gautam. How do you prevent infection among healthcare providers? Mr. Khanna.
Yeah. So one of the things I mentioned in passing is that all the areas in the hospital are mapped as per the risk assessment. So we have a red, green, and orange zone, and depending on whether you have exposure to the COVID patient, whether you are in close contact with a non-COVID patient, or whether you are in no contact, and there are other factors. So the when as per that classification, we have designed a level of PPE for each area. So some places there will be only a mask, only a surgical mask. Some places there will be an N95. Some places there will be N95 and a gown. Some places it will be a full PPE with a goggles and so on. So there is a risk-based gradation in the hospital. And I think the more important thing is when the hospitals start focusing on the safety of the employees and the patients who come in, and you practice this rigorously, the healthcare infection is reduced. For example, I would share with you, in our COVID, we have a separate building for COVID. The number of infections in our COVID building is absolutely nil. I mean, probably less than 0.1%. While the community, more patients, more staff has been infected because of the community and where they live than exposure to the COVID building. It's because the level of safety precautions which we take is much higher. So I think some places, as we were learning initially, many across the country, you found many healthcare workers were affected, but also because of what Dr. Reddy mentioned, and also there was no experience. They didn't understand how serious it is, and this thing about this fatigue is very, very real. That there is a 6-hour shift because once they are in a PPE, they cannot go out. So there's a 6-hour shift, a huge load. So, but if you provide adequate precaution, you provide alternate offs. We give breaks as per the government guidelines. I think we are well protected.
Right. That was a question from Dr. Arun Kumar. A question for Dr. Piramal. You've done work, with the rural settings, as you have said, with the foundations. So would empowering nursing staff be a more relevant step for a country like India, given the shortages in the remote areas? Could that be handled through empowering our the nursing staff? That's a question from Avinash Lodha.
Yeah, I think Jyoti, you also mentioned, and you've been working with us, overseeing a little bit of the work that we do, the Piramal Foundation, across 12 states of India and 25 districts of the poorest medical parameters, where we wonder what we can do with our doctors and nurses, actually, with just very bare primary healthcare staff, which is almost non-existent. It's a center, it's a building, but it doesn't have staff. And so this is when we came up with the idea of mobile healthcare services, because we know doctors don't go to the villages, nurses don't even go to the villages, primary healthcare centers don't have people. So we have a mobile healthcare service which works in every village once a week at a time, and there's 100% coverage during that time. And that has worked very well in states like Assam, the Northeast, Andhra Pradesh, which are very poorly health resourced. And that mobile healthcare service, looking at immunizations, maternal and infant mortality, making sure that the mother delivers in a place. And at COVID times, using telephone conferences, reaching out to the poorest, telling them what can be done, has really improved things at the rural level. So I think the rural level requires a different strategic thinking. It can't have doctors, nurses, hospitals, training. It doesn't even have a primary healthcare center that works. So we have to rethink our strategy to cover rural populations, frankly. And we have been doing very well before COVID, and during COVID have upped our volunteer workforce, 35,000, 50,000 volunteers working. And that has young people really want to do good for the nation, and they are so enthusiastic, and they are so easy to train, that we have used our youthful resource, the young of India, to help disseminate information on COVID, to look at helplines, to talk to people, contact tracing. So it has been a very effective way of getting young people in through the door. So I think rural areas need something completely different.
In fact, even in urban primary healthcare, technology-enabled non-physician healthcare providers can do a lot of good management. And just to supplement Dr. Piramal's point, in rural areas, we have had auxiliary nurse midwives having handheld digital devices with decision support algorithms for diabetes and hypertension. These auxiliary nurse midwives in state of Himachal Pradesh managed over 18 months to control blood pressure and diabetes with about 50 milligrams percent reduction in blood sugar, 15 millimeters reduction in systolic blood pressure. And that is a model that can easily be taken up. We do require some doctors, though, in primary health care, but we can actually, in most of primary health care, rural particularly, but also in urban, manage a lot with non-physician healthcare providers who are technology enabled.
We call it doctor in a box. In a box, having the equipment for a non-doctor to go and work in the rural areas.
Right. I know. Now we see that even with malaria, you have ASHA workers going with tablets into remote areas in Orissa and all of that. I know it's been a very engaging discussion, and since everyone's passionate about it, we can probably go on for a long time, but I think everyone's got other commitments as well. So I will wind up here. If anyone's got, if you would like to have your thoughts that you would like to leave, your audience with, we've covered a whole range of issues. Yeah, maybe starting with Dr. Piramal, and then Dr. Reddy and Mr. Khanna.
Our public health pillars: masking, social distancing, temperature control, the culture of an organization. All those, please don't forget.
Right. Dr. Reddy?
The virus will change its behavior if we change our behavior.
Excellent. And Mr. Khanna?
I just urge everybody to focus on preventive healthcare. Just take all precautions and take care of your health. This is the most precious asset you have.
Right. I'll just take a few minutes of yours first to thank the panelists for this very engaging conversation, and our audience for sending in those questions. Some of it was already discussed, so I do hope you found your answers there, or we'll meet up some other time, maybe again on these things. And a final thank you to our sponsors, Tata Mutual Fund. And before we wind up finally, just a little lead into next week, same place, same time. We have the Chief Economic Advisor, Mr. Krishnamurthy Subramaniam, who will be talking to BusinessLine's editor, Raghuveer Srinivasan. So don't forget to be there. Thank you all so much, and stay safe, everybody. Thank you. Have a good evening. Thank you.
You're welcome. You again.
Yeah, thank you. Bye-bye.